everyone, and I'm so excited and so honored that Sabrena Lee is our first guest of 2023. As Virginia said, she is the Deputy Director of North Carolina Medicaid Long-Term Services and Supports. She has other titles that we'll talk about: Vice Chair of Medicaid's Diversity, Equity, and Inclusion Council, Co-Chair of Medicaid's Strategic Business Operations Planning Committee. But so selfishly, Sabrena and I worked together closely 10 years ago on care transitions work and community resource connections work. And then our paths diverged around 10 years ago. So selfishly, I'm so excited that we have this catch-up time, and basically we've just invited the rest of you along. So Sabrena, before I hear and the others have here, because you've got some friends here, what you've been doing for the past decade or so, we always love to know a little bit personally about each of our guests and each of our coalition members. If you wouldn't mind sharing just a little bit about your background, where you grew up and what experiences shaped you.
Well, good morning. It's great to see you. And I also see some other names and faces that I recognize on the Zoom call this morning. Happy New Year to everyone. I am Sabrena Lee. I am a native Virginian, although I have roots in North Carolina on my father's side. Was reared in Virginia, educated in Virginia, but I've done some studies in North Carolina. Now I am the only child of my parents. And I share all these things because they shape who I am. I am the daughter of a school teacher and the daughter of a Baptist preacher. And I am a daughter of individuals who were involved in the civil rights movement, who continue to practice throughout both their careers, my mom and my dad, the concept of servant leadership. That was a part of what I saw growing up as a child. And that has shaped who I am, and certainly the approach I take to all of the opportunities I've had professionally throughout my career. In terms of career, I spent some time very, very early in my career as a therapeutic recreational specialist in a mental health hospital. I've done that work in a nursing facility. I've spent some time as a director of an Alzheimer's special care unit in a skilled nursing facility. Transitionally, I've spent some time as a long-term care ombudsman in metropolitan areas of the state and very, very rural areas of the state. I've worked in an area agency on aging, and I've been a community volunteer in communities where I've lived. And those things inform the work that I do today. My professional background is that of a specialist in gerontology. I have done some studies. I am a licensed and ordained clergy, so I've been to seminary. I've done some studying. Well, I completed a leadership program at Keenan Blazer. If I weren't wearing green today, I would likely be wearing black and gold because I am an avid Pittsburgh Steelers fan. So if there are Dolphins fans or Ravens fans or pretty much anybody that kept us out of the playoffs this year, I'm giving you side eye. In terms of ACC basketball, I am a Duke Blue Devil fan. So those are the things that inform me. I have been a part of the Department of Health and Human Services since 2007, and last month I celebrated my 10th year at the Division of Health Benefits, more informally known as NC Medicaid. And in that time, I've had major opportunities to be involved in some wonderful transformational activities that I believe cause us to be in a better place in our state in terms of long-term services and supports. And I'll stop there.
Sabrena, that was wonderful. There's so much I didn't know about you, and I respect so much about you, and I just am so inspired by you. And then you threw the Duke in there. It's like I was with you. Sure, I'll follow the Steelers too, but the Duke, it's okay. It's fine. Such rich experiences, and I didn't realize, and there's such a crossover with so many of the interests of members of the coalition, and clearly my interests as well, being in the aging space. So given your history, and I'm so glad that you shared that you're also part of ordained clergy, because I remember sort of seeing that part of you, and such a strong part of your leadership. What brought you into government? You had all of these interesting experiences personally and professionally, and then you landed in government services where you've been tucked away now for 10 years with Medicaid, but even 5 years, I think, before that. So what brought you there?
I think for me, and I joke about this because when I in fact came to the Department of Health and Human Services, it was my intention to only stay for 5 years. I thought getting the experience and background of state government would help to inform work I intended to do when I came back home to Greensboro. And my passion was working at the local level in an area agency on aging. And I thought that there was some missing knowledge that I would gain by coming to work for a short time in state government, and then at some point go back home to Greensboro, where I continue to live, and work there. But as Providence would have it, I found a new passion and I found a new opportunity. I've always at my heart valued the opportunity to be involved in system change, whether leading it or supporting it. And so the opportunity, I think what keeps me here and what keeps me commuting all these years is just the fact that systems change is a driver for me. And it is my passion, because there in discussions around diversity, equity, inclusion, we talk about being able to have courageous conversations and creating safe space. We talk about being uncomfortable or being comfortable being uncomfortable.
Yes.
And that's a skill set that I learned during my time as an ombudsman. But I think that's what led me here and what keeps me here for a little while longer.
I'm torn. I want to continue on that thread for us. We're going to go back to that thread. And I know I need lessons as someone who loves being comfortable and loves everyone to be happy and in a cheery space. But there are important conversations to have. In terms of context, as I look at you and I know others on the call right now, I know that we've got a group here that some are veterans of the coalition. Are veterans of government, know the Department of Health and Human Services quite well. Others, and I kind of put myself in this, Medicaid and the Division of Health Benefits or Department of Health, Division of Health Benefits, it's all sort of a mystery to me. Take a moment just for context to share what does the office do? Sort of what are your responsibilities when someone says I work in this division or work for Medicaid? What does that mean?
Well, so NC Medicaid, Division of Health Benefits, is one of the divisions within the Department of Health and Human Services. I think there are probably about 13, don't quote me on that, because it changes divisions now. And our task at the Medicaid program or health benefits is to administer North Carolina's contract with CMS, our federal partner, is to administer the Medicaid program. And so at this point, since July 1st, 2021, we have been administering the Medicaid program with two service delivery systems. One being our fee-for-service service delivery system. The other now, since 2021, being our standard plan, our prepaid health plan, managed care. So how do we do that? Well, North Carolina has a contract with the Centers for Medicare and Medicaid Services to administer health care to North Carolinians who, because of their socioeconomic status or because of the complexities of their health care, cannot afford or do not have private insurance, cannot afford the care or the coverage of their healthcare costs. And so Medicaid administers that program. There are certain programs that, when you participate federally, are required for a state, and then there are optional programs that you can elect to have. People kind of glaze over when I start to talk about SPAs, which are state plan amendments, not the nice place that you go and relax. People are starting to hear and hear about waivers. And so those are types of authorities that we have or contracts that we have with the federal partners to administer services. The different types of waivers give different types of flexibilities. And certainly with COVID, we all got to hear about the flexibilities that came fast and furious in the Medicaid program that allowed us to suspend doing certain things, or allowed us or prohibit us from disenrolling people in the Medicaid program. I'm going to stop there because I could talk for an hour about that, and I don't think you want me to.
No. Well, actually, I would. I wish we had more time. And then your role in it. So is it, hey, can we do this waiver? Let's ask Sabrena. Let's make it happen. Or, how does? Well, we're going to talk about government. Like, how do things actually get done?
So my portfolio as deputy director, and I'm one of about, I think maybe 5 individuals. My portfolio is long-term services and supports. And LTSS crosses the lifespan because we provide long-term services and supports to children who were born today with a special need, who will require healthcare services and supports for the entirety of their life until the end of life. And so we have the state plan services that are home and community based. We have a waiver, CAP DA. We have a waiver for children, CAP C. Our portfolio has all of the rehabilitative services, home health, hospice, private duty nursing. We provide personal care services. We do have a managed care product. The PACE program falls in my portfolio. What else? HIV, case management. I hold the dual special needs contracts. We have about 16 in North Carolina that serve over 100,000 lives today. Last year, we spent $9.7 billion in long-term services and supports. So we have 7 state plan amendments, personal care, home health, hospice. Those are all state plan amendments. We operate our PACE program as a state plan service, which means, and the importance of that is, if you need the service, you get it, which is different from our CAP DA and our CAP C waivers, which are programs that are limited in the number of slots and targeted to certain populations based on needs. I also have the nursing home program, and this is both on the fee-for-service side and on the managed care side. And as you all are aware, in just a few months, we will launch the tailored plans. And so the LTSS that is involved in tailored plan is also part of my portfolio. So if you want to change something, do you call me? Fortunately not.
Okay.
But sometimes people try that, and that's okay too. But we have I think, very robust stakeholder engagement process that checks in with our stakeholders, both providers and beneficiary and member stakeholders, with some regularity. That helps to inform the work that we do. We often are doing our best to stay on top of standards of practice and participate federally on work groups. Right now, we're involved with the Division of Aging and Adult Services with their master plan on aging.
Yes.
And so that's one of the ways that we stay abreast of what needs to change and improve.
Oh, okay. So this is where time is not our friend, but you just hit on so many passion areas of not just members of the coalition, but I know a number of the other people who are on the call right now, and I know people's minds are like, oh my gosh, how do we talk to Sabrena about this? Or how do we work on this? So let this be the first of a few conversations on Friday Facts, or maybe with the membership meeting, because long-term services and support across the lifespan, how those, because our coalition, we have a whole pediatric membership and then all the way through older adult world. So you just touched on clearly, and with over 9 billion anyway of dollars spent. So thank you for all you do. And I know there's going to be a lot of questions and conversations that happen afterwards about how to factor this into the planning of how we make change. And so speaking of change, because I do want to go back with the time, there's a few things I want to talk about. We talked about before we got on the call about how you stay, well, I'll ask it now. Given all of the work that's happening and given your history, how do you stay so resilient, given that working in government and the whole host of issues you just put out, or the different programs, working in government can be complicated, and often it can be a thankless job. How do you stay motivated? Because so many important things you just shared, but easy to get.
I feel very, very fortunate that very early in my career, I found my passion. And on the occasions I have to talk to people on the front end of their career, I say the sooner you can find your passion, then the sooner you will find the motivation and the resilience to do whatever it is that's in front of you. And I shared with you that particularly around COVID was an inflection point for us, because we were doing things and getting ready for managed care that were stressors, and then comes COVID. And when you're under pressure, you kind of reveal who you are. And what I shared with you earlier was that I had the opportunity, because we were under pressure, meaning up close and personal, to understand that while we might not be of the same mind, we were of the same heart. And when you have the opportunity to see someone's heart, then that creates the opportunity to get aligned in your mind. And what I said to you, because you know me, is that I have always believed myself to be a fairly persuasive individual. That's that Baptist preacher gene that I have. And so I believe in the power of persuasion, particularly if you know you are of the same heart as an individual. And if you are of the same heart, then that creates the foundation for what I mentioned before, courageous conversations. Why don't you agree that this is what we need to do? And if you are of the same heart, then when you're having those courageous conversations, you understand that you just need to align. It may not happen when you want it to, but eventually you find alignment, and that's the resilience piece.
And goes to faith, also faith that you can find that connection there. I do want to circle back to our own courageous conversation and the passion that you just spoke of, and you have shared that your passion, you shared it with us a few minutes ago. You and I have talked about it beforehand and preparing your work around health equity. I do want to come back now to your work around diversity, equity, inclusion. As you shared with me, you are vice chair of Medicaid's Diversity, Equity, and Inclusion Council. What does that work look like for you? What does that work look like with Medicaid? Love to hear about that.
Well, so I'll talk about my professional training and my and talk about the fact that lately, around this work of DEI and health equity, I've been trying to decide at what point living becomes aging, because and where I've concluded is that living becomes aging when life gets interrupted by illness and disability, illness and or disability. So and as an individual who is aging, and years ago now got an AARP card and have had to confront some health issues of my own, and I am a caregiver for a robust 90-year-old who is now starting to have some chronic health issues that impact her. So this notion of when does living become aging is informed by the DEI work, because if in fact we start to think of aging itself as a disability, or if we make the mistake of creating a situation where we're othering folks, then we disadvantage and we limit our capacity to understand and be inclusive across the lifespan. And so I think for me, in terms of the work that I do in LTSS, when someone talks to me about wanting to do a particular service, and an easy one is lowering the curbing on sidewalks so that a presumably elderly person in a wheelchair or on a walker don't have to traverse that step or trip. And in my mind, that same benefit for the older adult benefits a young person who is in a mobile chair, or a mom or dad pushing a stroller of their child, whether disabled or not. And so for me, looking at opportunities to be inclusive, obviously around health equity, looking for unintended consequences of our policies that suppress utilization is health equity. DEI is how we support our workforce. We're now looking at a workforce where we literally, in some cases, I think I maybe have 4 generations of people. I have a staff of 60 of the most incredible healthcare professionals you would ever want to meet. North Carolina is so blessed to have them on our team. But I've got 4 generations of people that I'm interacting with, that I'm leading. And so understanding the nuances of those generational dynamics is very, very important. So I could go on, but I'll stop.
No, I want you to go on. You're again touching on so many issues and finding ways to connect and to bring forth I guess enough understanding so that way people can move forward together. I'm rambling on because I, as always, I'm back in that place 10 years ago when I'm like, Sabrena, tell me more. It's just, oh gosh. We have just a few minutes left, and I know that people in the coalition are going to want to know about your priorities. These are the questions that we have, your priorities for the next year that folks should know about, and also, selfishly ways we can work together, because I know I'm taking notes. I know others are like, how can we work together more with you and the coalition, more with your 60 amazing team members? So I'll leave it at that, with priorities and collaboration.
So because we are part of the Department of Health and Human Services, the strategic priorities that we are aligned around are behavioral health and resilience, child and family well-being, again, across the lifespan, and a strong and inclusive workforce. Certainly, we are aware that in terms of long-term services and supports, government is the principal funder. And in Medicaid, we have two basic levers that drive change. One is policy, and the other is pay. And so how will we use those levers of policy and pay to accomplish those strategic goals? Certainly, our change in pay system, moving from fee-for-service to managed care, has yielded initially some good results. We've learned some things. Allowing the waiver flexibilities that are available, because we're administering managed care using an 1115 waiver, and all you need to know about that is that that's a demonstration waiver, and it allows us to utilize funds in a flexible way. The best example I know about that I can offer you in this short time is our Healthy Opportunities Initiative, where we're looking at how we can leverage, again, our pay to create housing for people who are experiencing housing insecurity, to create supplemental nutrition above that which we traditionally see for people experiencing food insecurity, improving our transportation system, because one big issue in terms of health equity is access to services, that's transportation, and then interpersonal safety. So leveraging the flexibilities of the waiver to address what we call social determinants of health. So I'm focusing on how we can do that. Certainly you are aware that at this point, dually eligible individuals are not enrolled in our managed care program. However, I mentioned before that we do have DSNP contracts, dual special needs programs. And there are some flexibilities that the federal government now allows us to leverage to incorporate some of the same things we're seeing on the managed care side in our DSNP contracts. And so that's certainly one of my focuses. I'm also focused on expanding how we use our CAP waivers. Certainly 10 years ago, we didn't have consumer direction, or 2007, when I came to North Carolina, one of the first projects I got to work on was bringing consumer direction. And we don't, now that's just, that's something we do. But how can we leverage consumer direction that's available in our waivers to address our workforce issues and to support families? Expanding our waivers, both our CAP-DA and our CAP-C waivers are being amended and renewed. And we've added some additional products to those waivers to create flexibility. Certainly looking at how we can leverage all of our programs to support the Olmstead plan that we have and the transitions to community living. Those individuals are going to need services and supports. And then lastly, the thing that I'm interested in and focused on is creating the appropriate glide path to transition long-term services and supports into managed care by looking at the lessons we've learned from those who are enrolled and tweaking our policies so that when that time comes, it's not a cumbersome transition.
There's so much depth in all that you've shared, and I feel like, and then I'm just moving us along because each one of those could take their own half an hour to dive into. So basically, you're not doing anything for the next year. No, there's so much happening, and then even doubly honored that you would take time to talk with us. But how do we continue this conversation? You've got the coalition has 180 members. We're all over North Carolina. We really represent in so many different ways the voice of those with serious illness, providers, caregivers, many organizations, as well as individuals. How do we support your work? How do we help to be a part of this collective through policy work, through our government partners with you?
Well, first of all, by continuing to do what you do, a number of folks are on this call, shoot me emails and share very valuable information. Did you see this? Did you hear this? Do you know this? Continue to do that. If you see that I'm missing something, pick up the phone like Mary Bethel does and call me and say, Sabrina, I need to talk to you. I do answer, and I am responsive. One of the things that I am working on this year is sort of a realignment of our stakeholder engagement to be more inclusive. I have been blessed and am honored when asked to participate on NCIOM work groups and study sessions. And if I'm not present, I have folks who are present, who are listening, and then we talk about what we hear. And I have been known to sit in on that meeting and then call somebody after that meeting and go, I want to know more about what you're doing. And so those types of opportunities are extraordinarily helpful. I will say the one thing I'm going to say about this and leave it, because you don't have a bleep button, and that is to help us promote Medicaid expansion. The time is now, and it's needed, particularly now that it appears that the public health emergency will be sunsetting this spring. There will be people who will be adversely affected from that if we had Medicaid expansion, won't be kicked off only to be put back on, or worse yet, kicked off and lose health care. That's the only thing I'm going to say about that. But those are the things that are very, very helpful to me. We're going to have some work groups. We've got a couple of projects that I actually didn't mention intentionally that I'll be extending invitations for folks to participate on. And when you receive the invitation, please be responsive. Certainly, I'll put in a plug for the master plan on aging work that we're partnering with Joyce and the folks at DAAS to do. That will require an all hands on deck approach to move that needle. And so when you receive an invitation to be on one of those work groups, please accept that.
All right. Well, we're so happy to be a part of your stakeholder group. We're happy you're a part of our stakeholder group. I know in the interest of time, I have to shut this down, but this is the beginning of continuing on. And thank you. And I know personally, I know, and you shared how close you are with your parents and that you were motivated by their servant leadership. And I continue to be motivated by your servant leadership. And let me just say thank you. Thank you for sure for being on Friday Facts, but thank you for all you do. And it sounds so grand, but it's so true. Thank you for all you do on behalf of North Carolinians. It is so, you really have made such an impact, and I know you continue. You're seeing the thank you start to come in. With that, we'll end Friday Facts, and thank you to all, and welcome to 2023. All right, thanks.